Good morning. To kick off rounds today, I've put together this explainer on our patient Dale and his decompensated liver disease. We're looking at a classic, albeit incredibly severe, case of cirrhosis complicated by portal hypertension, varices, hepatic encephalopathy, and now hepatorenal syndrome. Let's dive right into this case together. I want to walk you through exactly how his systemic collapse unfolded, the clinical reasoning behind our diagnoses, and how we are actively managing his care on the ward. Right out of the gate, I want to outline Dale's critical admission vitals and presenting symptoms. He was brought in by his sister, presenting with a blood pressure of 96/58 and a heart rate of 104. He's had 2 days of black, tarry stools and 3 days of confusion that's notably worse at night. I want to emphasize this immediately because it makes it absolutely clear that we are dealing with active, multi-system decompensation. The fatal complications of his cirrhosis are literally in the room with us. So I'll structure our rounds today into 5 parts. We'll start with the admission presentation, move into a deep dive of the underlying pathophysiology, tackle our assessment and acute complications, look specifically at his day 4 renal failure, and finally wrap up with his disposition and some core teaching pearls. Part 1, the admission presentation. Let's set the stage with his specific history to see why his presentation warranted such an aggressive workup from the second he hit our doors. Dale is a 54-year-old long-haul driver. His sister noted his abdominal girth has actually been rising for 3 weeks now. Looking at his background, there are several massive red flags. He's had untreated hepatitis C for 12 years. On top of that, he drinks a pint of vodka a day and has done so for 20 years. He takes ibuprofen for back pain, he's erratic with his prescribed diuretics, and crucially, he has never had a screening endoscopy. Oh, and he stopped taking his lactulose 2 weeks ago. Now, the most vital clue here is actually a negative finding. He has 0 fever and 0 abdominal pain. Why does that matter? Well, when we are trying to figure out what tipped a cirrhotic patient's brain into confusion, bleeding and infection are the usual culprits. The absolute absence of fever or belly pain narrows our focus significantly toward the bleeding. Moving to his physical exam, we can practically split his findings down the middle into 2 distinct disease pathways. This proves to us that he has signs of both profound synthetic liver failure and severe portal hypertension. On the liver failure side, the signs of a dying organ are everywhere. Jaundice, which you typically see when bilirubin crosses above 2.5, along with asterixis, spider angiomas, and palmar erythema. On the portal hypertension side, which is effectively a massive plumbing issue, we see the physical manifestations of back pressure, ascites, splenomegaly, caput medusa, and a Cuvier Baumgarten venous hum. Dale is physically exhibiting both families of findings. Let's run through his admission labs. His bilirubin is significantly elevated at 4.8, and his albumin is low at 2.6. That confirms the synthetic failure. The aminotransferases are a bit variable, but his AST is 96 and ALT is 41. That AST above ALT ratio, that's highly typical in late-stage alcohol-related disease. Notice the hyponatremia at 128. This is hormone-driven water retention caused by a low effective arterial volume. We also see thrombocytopenia with platelets at 74, which points to a large, overactive spleen chewing them up. And lastly, I want to heavily flag his baseline creatinine of 0.9. Keep that number in your back pocket. It's going to be incredibly important later. Part 2, the pathophysiology deep dive. I want to defend my clinical reasoning by breaking down exactly how Dale's liver reached this state of failure. We can build his cirrhosis in 4 structural steps. It starts with chronic injury, sustained over years. In Dale's case, the dual insult of untreated hep C and heavy alcohol use. This ongoing injury leads to step 2, fibrosis and regenerative nodules replacing normal liver tissue. That brings us to step 3, where the actual vascular architecture of the liver becomes highly distorted. Finally, this structural chaos forces the portal pressure to rise. So the core plumbing issue driving all his complications is portal hypertension, specifically defined as a hepatic venous pressure gradient above 5 millimeters of mercury. Remember, decompensation means a variceal bleed, ascites, or encephalopathy. Dale arrived with 2 out of the 3. Let's see how this builds into the downstream pathophysiology for both the brain and the kidney. For the brain, the liver has essentially stopped doing its job. It fails to detoxify, allowing ammonia and other unclear toxins like edema to build up in the blood. These bypass the liver, cross into the brain, and drive cerebral edema. Oxygen consumption falls, reactive oxygen species rise, and this directly causes his confusion and asterixis. Now, for the kidney, the mechanism is entirely different. Driven by systemic vasodilation from the advanced liver disease, three major systems aggressively fire in a panic to compensate: sympathetic tone, the renin-angiotensin-aldosterone system, or RAAS, and vasopressin. This massive compensation causes severe renal vessel constriction, blood flow drops, and as creatinine climbs. The absolutely vital concept here is that the kidney is being starved, but structurally, it is completely normal. Before we move to active management, I have to explicitly caution against a massive clinical trap. Dale's INR on admission is 1.9, but the INR is not bleeding time in cirrhosis. It correlates horribly with actual bleeding risk. Why? Because while the liver isn't making many pro-clotting factors, factor 8 is usually normal, and both the procoagulants and anticoagulants fall together in these patients. A number alone does not justify giving plasma, and we absolutely will not chase this 1.9 with fresh frozen plasma. Notice the stark difference here regarding the vascular risk he's facing. The presence of varices tracks tightly with the severity of the liver disease. While 40% of child Class A patients have varices, that number skyrockets to 85% for child Class C patients like Dale. These varices are thin-walled collaterals. They were never built to handle this kind of portal blood pressure. When we are predicting which varices will actually rupture, the bleeding risk comes down to larger varix size, being child Class B or C, and the presence of red whale marks on endoscopy. Part 3. Assessment, Plan, and Ward Management. Let's score his prognosis aloud right here at the bedside using the Child-Turcotte-Pugh criteria, which relies on 5 inputs. His bilirubin is 4.8, which gives him 3 points. His albumin is 2.6, so that's another 3 points. His moderate ascites adds 3 points, the INR of 1.9 adds 2 points, and his grade 2 encephalopathy adds a final 2 points. That's a total of 13 points. This firmly places him in Class C. I have to warn the team, his 1-year survival rate is dangerously close to 45%. His MELD score, which is our main metric for transplant prioritization based on bilirubin, INR, creatinine, and sodium, is sitting in the high 20s. Addressing his variceal bleed, our ward management is incredibly strict. At presentation, we started ceftriaxone 1 gram IV daily for 5 days. This is mandatory for any cirrhotic with a GI bleed. It results in fewer infections, less rebleeding, and lower mortality. He's already undergone endoscopic banding, but because about 50% of these patients will rebleed, our secondary prevention has to be aggressive. After a first bleed, every single patient gets both a beta blocker and a banding program. We use carvedilol titrated to the maximum tolerated dose, keeping his systolic blood pressure at or above 90. Endoscopic banding is repeated every 1 to 4 weeks until the varices are gone. If the bleeding is refractory, we'd move to an early TIPS procedure. Now, doing an early TIPS within 72 hours for high-risk child B or C patients definitely cuts rebleeding, but we have to remember it raises the risk of encephalopathy with no overall mortality gain. This brings us to a really critical diagnostic question for our team. What tipped his brain into clinical encephalopathy? In any cirrhotic with a depressed level of consciousness, we always have to hunt the precipitant. We've ruled out infection, dehydration, and hypoxia. Looking at his history, the triggers are glaringly obvious. His precipitants are the massive protein load from the blood sitting in his GI tract and his non-adherence, specifically the missed lactulose for the past 2 weeks. So our treatment plan targets these directly. We're restarting lactulose to acidify his colon and convert toxic ammonia into non-absorbable ammonia. Crucially, the goal is 2 to 4 soft stools daily, not 10. Overshooting just causes volume depletion, which will only make the encephalopathy worse. And because lactulose alone isn't enough for his severe state, we are adding rifaximin 550 milligrams twice daily to decrease those ammonia-producing gut bacteria. Finally, we diligently need to keep his potassium above 4, avoiding alkalosis, which can drive ammonia straight into the brain. Let's aggressively bust another myth right now. We will not be tracking Dale's serum ammonia levels. Serum ammonia is a famously poor test. It neither makes nor follows the diagnosis of hepatic encephalopathy. The diagnosis stays purely clinical. It relies entirely on our history, our physical examination, and the presence of asterixis. Do not treat the number, treat the patient. Part 4. Hepatorenal syndrome. Transitioning to hospital day 4, we hit a terrifying wall. Despite our initial interventions, Dale's creatinine just climbed from his baseline of 0.9 all the way up to 2.4 today. We have to separate this from prerenal azotemia, tubular necrosis, and NSAID toxicity to see if this is hepatorenal syndrome. This is a diagnosis made entirely by subtraction, and I'll defend it right now by proving he meets all 6 strict criteria. 1. He has cirrhosis with ascites. 2. His creatinine is up 0.3 in 48 hours or over 50% from baseline. 3. We held his diuretics and gave albumin at 1 gram per kilogram per day for 2 days with no response, so it's not simple dehydration or prerenal azotemia. 4. There is no shock. 5. There are no nephrotoxins on board as his ibuprofen was stopped immediately. And 6. He has no intrinsic kidney disease. His urine sediment is completely bland, ruling out acute tubular necrosis. He meets all 6. We are officially dealing with hepatorenal syndrome. For the ward management of his HRS, we stratify by illness severity. He's not critically ill and shock, so we aren't using potent ICU IV meds like terlipressin or norepinephrine with albumin to raise his MAP by 10. Instead, we are initiating pharmacological rescue right here on the floor. The regimen is octreotide 100 to 200 micrograms subcutaneously 3 times daily, combined with midodrine up to 15 milligrams by mouth 3 times daily. This is given alongside albumin, 1 gram per kilogram on day 1, maxing at 100 grams, followed by 20 to 60 grams daily. These vasoconstrictors attempt to counter that massive splanchnic vasodilation. And I must clearly articulate this. His carvedilol, the beta blocker we just started, must be held immediately. We absolutely cannot have him on a blood pressure-lowering agent while he is hypotensive in HRS. His renal perfusion has to recover first.
Part 5, Disposition and Pearls.
For our final act, let's look at Dale's long-term trajectory. It's incredibly important to contrast the two forms of hepatorenal syndrome. There is HRS-CKD, which is an indolent course with a median survival of about 6 months. But Dale has the acute kidney injury form, HRS-AKI. This develops in under 2 weeks, usually following a major precipitating event like his GI bleed. It puts him on a very short clock. Median survival is roughly 2 weeks. If our vasoconstrictors fail, dialysis or a shunt may be required, but we have to recognize those only serve as a temporary bridge to transplant.
Looking ahead to his final disposition, assuming we stabilize his kidneys, his variceal banding program, lactulose and rifaximin, will continue indefinitely. Solving the underlying insults is non-negotiable. The ibuprofen and the alcohol must stop for good, and his hepatitis C finally needs to get treated. But ultimately, his Class C status drives an immediate liver transplant conversation.
I'll close our rounds with these absolute rules of cirrhosis management to ensure we avoid the classic pitfalls. First, the INR is not a bleeding time, and ammonia neither makes nor follows the diagnosis of encephalopathy. Second, NSAIDs like ibuprofen have absolutely no place in cirrhosis. Third, combination therapy with a beta blocker plus banding happens after a bleed, not before. And finally, every single new diagnosis of cirrhosis earns a screening endoscopy. This leaves us with a final provocative thought. If we had caught this early, could a simple screening endoscopy 12 years ago have prevented Dale's entire systemic collapse today? Thank you for joining me on Rounds.